Thank you so much, Dr. Afra. I'd like to thank the organizing committee for this great event, and would like to thank them for letting me part of it. So today I'll talk about von Willebrand disease. Objectives are to go over introduction of von Willebrand antigen and disease, to discuss classification of the congenital and acquired forms, and to discuss some laboratory testing. So von Willebrand antigen is a large multimeric glycoprotein that is synthesized in the endothelial cells and megakaryocytes, and then it's stored in the Willebrand bodies and alpha granules of the platelets and endothelial cells. Now, this process is really complex. That starts with the synthesis of the protein, transportation, multimerization, and dimerization, and ends by release of an ultra-large molecular weight von Willebrand factor that is the most hemostatistically potent form of the protein. ADAMTS13 is a very important cleavage protein that is responsible for cleaving those very potent components. Now, looking at a monomer, von Willebrand monomer, it has many domains that interact with different proteins, including D-D3 that interacts with factor VIII, a one domain that interacts with glycoprotein 1b alpha of the platelets, ristocetin, and collagen. Collagen also has another binding site at A3 domain, and alpha-2b beta-3 integrin of the platelets bind at C4 domain. So it has multiple binding proteins. Now, the functions of von Willebrand include that at sites of injury, VWF bridges platelets to the vascular subendothelium, and this is the platelet adhesion. And at high shear stress, activated platelets express alpha-2b beta-3, which binds VWF and fibrinogen, and this is the platelet aggregation. And finally, it's a chaperone or a carrier for factor VIII that extensively extends the half-life of factor VIII and maintains normal plasma level. So as you can see, von Willebrand factor has important roles in both primary and secondary hemostasis. Now, von Willebrand disease was first described by Dr. Eric von Willebrand in 1926 on a Scandinavian family, and the index case died of menorrhagia during her fourth menstrual cycle. It is by far the most common inherited bleeding disorder, accounting for 1 in 100 to 1 in 10,000. And this is, although a relatively old study, but it's a local one that retrospectively collected patients over 8 years and analyzed patients with hereditary bleeding disorders. So it shed light on the proportion of von Willebrand disease in our population, which comprised around 15% of them. So patients usually present with mucocutaneous bleeding, as in extensive bruises, epistaxis, gum bleeds, and menorrhagia. They also can present with prolonged bleeding from minor wounds, bleeding after dental work, childbirth, and surgery. And in the most severe form, we get musculoskeletal bleeding, especially when factor VIII is really severely affected. This is another local study that looked at bleeding patterns in patients with von Willebrand disease that showed the most common bleeding pattern was combined bleeding followed by joints and muscle bleeding, suggesting a more severe form of the disease. Now, classification of von Willebrand, it's classified into 3 types, 1 and 3 being the quantitative deficiency of a normal protein, Type 2 being the qualitative or a defective protein. Now, type 1 is a quantitative deficiency of von Willebrand factor, where there is concordant reduction of both the activity and the antigen. It is caused by missense or null allele mutation, in this case, a heterozygous or carrier state, and it's an autosomal dominant disease. It is the most common form of von Willebrand disease and is defined as VWF below 0.30, regardless of bleeding pattern, or below 50 with abnormal bleeding. Factor VIII usually fall in parallel with von Willebrand, so usually you find factor VIII at about 1.5 that of von Willebrand. And type 1C is an interesting subentity of type 1 that shows significantly increased clearance, that's why it's called C. It comprises around 15% of cases, and treatment may be impacted due to the short half-life of von Willebrand disease, as patients are not really good candidates for desmopressin therapy. Type 1 Vicenza, some patients with type 1C, they show ultra-large molecular weight multimers, and this is explained by high turnover of VWF, which does not give enough time for ADAMTS13 cleavage, resulting in the presence of recently secreted ultra-large molecular weight multimers. So both 1C and 1 Vicenza indicate really increased clearance of the protein. Now, type 2 is the qualitative defects in von Willebrand factor, where there is discordant decreases between the activity and antigen. Type 2A is the most common form of type 2, and it's autosomal dominant disease that results in loss of intermediate and high molecular weight multimers. And again, these are the most potent, hemostatistically potent factor. And this results in diminished platelet binding. Type 2B is another interesting entity in type 2. It's autosomal dominant, and it is caused by by a gain of function mutation of the A1 domain, resulting in significantly increased binding to glycoprotein 1B alpha on the platelets. This significantly increases the interaction and causes accelerated clearance of patients and the high molecular weight multimers. Now, patients are not infrequently misdiagnosed as ITP in this entity. And however, I want to point out that thrombocytopenia, although is seen in the majority of patients, is not necessarily present in all of them. When we talk about 2B, the other entity that mimics it clinically is the platelet type pseudo von Willebrand disease. It's caused by a mutation in the glycoprotein 1BA gene of the platelet rather than a mutation in the von Willebrand disease. And there is rationale to differentiate between these two entities. In terms of the therapy, if the patient needs replacement, will you give platelets or VWF concentrates? Now, although I'll be talking about laboratory at the end, I thought it's best to discuss ristocetin-induced platelet aggregation, or RIPA, here, because it has characteristic findings in type 2B. So it measures the affinity of VWF binding to glycoprotein 1B in the presence of different concentrations of ristocetin, and then the platelet aggregation is recorded. So this is a normal result from a normal donor, and as you can see, a high-dose ristocetin should produce this normal aggregation response. However, the low-dose ristocetin should not cause any response in a normal individual. In the contrary, this is a patient with either type 2B von Willebrand or the pseudo von Willebrand, where the patient is showing abnormal aggregation to low-dose ristocetin that's usually 0.5 milligram per ml. Now, other abnormalities that can be seen in RIPA is reduced responses to the higher concentration of ristocetin, including type 1, 3, 2A, 2M von Willebrand disease. Now, what we do next is just to separate or differentiate between type 2B and the pseudo von Willebrand, is that we mix patient plasma with controlled platelets or patient platelets with control plasma. So which one is type 2B and which one is platelet type von Willebrand disease? The left panel shows a type 2B where the defect is in the patient plasma containing the von Willebrand disease, whereas on the right side, the platelets are really the defected component. So as for the recommendations that we have, the upper side is the BSH guideline, although relatively old now. They specify that it should be, or they recommended RIPA for all patients with reduced VWF activity to antigen or with patients who have thrombocytopenia. The more recent consensus guideline published in 2021 suggests targeted genetic testing for these patients over RIPA. Now, this is a suggested, so it's a conditional recommendation with low certainty in the evidence. So it depends really on what you have in the lab to confirm these patients. Next is type 2N. Is a rare subgroup. It's an autosomal recessive disease. It's caused by missense mutation in D-D3 domain that causes reduced binding to factor VIII. And you will see disproportionately lower levels of factor VIII compared to von Willebrand. Remember, I told you in type 1, usually it's about 1.5 that of the antigen. And the clinical manifestations can mimic hemophilia with critical therapeutic implications. Next is type 2M, where it's caused by mutations in the, again, A1 domain, so like type 2B. However, here there is defected binding rather than a gain-of-function mutation. It causes decreased interaction with the platelet, and this is by far more common than a collagen binding defect. Now, 2M has the most challenging in terms of really allocating patients in this right group. So think about it in patients who don't fulfill criteria for type 1 or other entities of type 2. Now, finally, type 3 is homozygous or compound heterozygous of a null VWF allele. Usually, it's an autosomal recessive disease and causes severe deficiency or virtual loss of the protein. Severe bleeding, patients present with severe bleeding patterns that can mimic hemophilia, again with significantly reduced factor VIII. So that was the congenital von Willebrand. I thought about discussing acquired von Willebrand syndrome today because it's a really underestimated bleeding disorder. It was first recognized 50 years ago, and the laboratory findings are similar to what we see in the congenital forms. And we should suspect it in adults or pediatric patients with no personal or family history of bleeding. Now, what causes acquired von Willebrand syndrome are really many reasons that include antibody-mediated, as in monoclonal gammopathy, lymphomas, and autoimmune diseases. High shear stress, as in any valvular stenosis, obstructive cardiomyopathy, or extracorporeal devices like ECMO and left ventricular assist devices. It can also, von Willebrand can adsorb onto cells or proteins like what we see in Wilms tumor, lymphomas, essential thrombocythemia, and multiple myeloma. Less commonly is that there is decreased production, as in hypothyroidism, which is a general state that causes reduced protein synthesis. So the most common form is really increased clearance of the protein. So in some patients with valvular defect, particularly aortic stenosis or severe mitral regurg, this high shear stress activates von Willebrand and causes its premature clearance from the circulation. So these patients acquire von Willebrand syndrome. Now, von Willebrand was linked to the suppression of angiogenesis via many mechanisms, including changes in the vascular endothelial growth factor. So these patients might develop submucosal angiodysplasia and lower GI bleeding. Now, this is what we know as Hyde syndrome, although causality hasn't been really confirmed, but many reports show that the correction of these valvular defects results in dramatic improvement in their bleeding pattern. As for the laboratory testing, VWF panel should include at a minimum factor VIII activity, VWF antigen, and activity level. And what we do is that we derive the activity to antigen ratio. This could be 0.6 to 0.7. If you have a laboratory-derived reference in your lab, you should refer to that. However, most guidelines recommend 0.6 to 0.7. Recent guideline recommended that 0.5 is too low for that. And as for APTT is often normal unless factor VIII is reduced to below the level of the assay sensitivity, that's usually 30 units. Now, as for factor VIII activity, it's a one-stage APTT-based assay that is usually measured by a clot-based or an optical assay, depending on the analyzer you have in the lab. VWF antigen level is done by immunological assays that historically were ELISA, the famous 96 well plastic tubes. And then now it has been replaced, I would say, in the majority of places by the latex immunoassays, or what we call LEA testing. So briefly, latex beads coated with anti-VWF antibodies are added to patient plasma, and agglutination of the beads that is proportional to the level of the antigen is read by a spectrophotometer. It's widely available and readily automated. However, we should be careful with patients who have rheumatoid factor or heterophil antibodies. This can cause erroneous results and erroneously higher results of the antigen. Now, both ELISA and LEA have really good characteristic performance. Next, we do have the newer assays, or what we call chemiluminescence assays, CLIA. Briefly, magnetic particles that are coated with anti-VWF antibodies are added to the patient plasma, and binding causes light emission that is directly proportional to the concentration of the antigen. So far, it shows really the best low level of sensitivity. Now, this is critical when we deal with patients with a level below our detection, for example, below 10% of the von Willebrand. So to differentiate between severe type 1 and type 3 disease, this will have a really added role. And however, it's not really widely available. Finally, we want to test different aspects of VWF activity. So first, we measure the glycoprotein binding, which occurs by binding at the A1 domain. So we have different assays for that, starting with VWF ristocetin cofactor. So what is ristocetin? It is an antibiotic, originally an antibiotic that binds to the patient's VWF in plasma and causes unfolding to permit binding to glycoprotein 1b. And then we add control platelets and platelet aggregation that is proportional now to the function or activity of VWF are recorded. Now we have fully automated assays, and this is what we're currently doing at King Fahd Medical City. Now, newer assays, immunological assays that measure the protein, the function, are a VWF glycoprotein 1BR and 1BM. We call them platelet-free because we don't need control platelets. So glycoprotein 1BR assays that are based on the ristocetin-induced binding of VWF to a recombinant wild-type glycoprotein 1b fragments, and VWF glycoprotein 1BM assays that are based on the spontaneous binding of VWF to a gain-of-function mutant fragment. So in this case, we don't use ristocetin. This is important because some patients have polymorphism in the antigen that can affect the binding of ristocetin. Now, they generate comparable results to the VWF ristocetin cofactor assay. And the most recent consensus guidelines suggests newer assays over the ristocetin cofactor. Again, this is suggests, so it's a conditional recommendation. Moving on to the binding of von Willebrand to the collagen, what we call VWF collagen binding, is to assess adhesion to the subendothelium. It's usually done by ELISA testing, and we have newer CLIA testing coming. And finally, we measure VWF binding to factor VIII by ELISA testing. Now, the multimer analysis, another modality that we use, is really nice in separating subtypes of type 2 disease. So it's a qualitative visual assessment of the size or band pattern of VWF multimers, where separation is based on the size or molecular weight of the protein. However, it's really complex and time-consuming. So this is an example of a normal pooled plasma where you see a spectrum of bands starting from high molecular weight to smaller forms. And as we move type 1, although they're not really indicated in type 1, but they will show like all forms of the band, but with a less intense pattern compared to the normal. Type 2 and B show loss of high molecular weight multimers, and type 3 shows like virtual loss of the protein. Now, it's really important to remember that type 2M does not show loss of high molecular weight multimers. To summarize what we just discussed, type 1 disease shows a normal activity to antigen ratio with normal pattern but reduced intensity of the multimers. Type 2A and 2B show low activity, glycoprotein 1B, and collagen binding to antigen ratio with loss of high molecular weight. Type 2M, the common form of the platelet binding defect, shows low glycoprotein 1B binding with no loss of the high molecular weight multimers. And this is the opposite in the less common form. Type 2 Normandy shows just a low factor 8 to VWF ratio with normal pattern, and the virtual loss in type 3 is noted. Now, just briefly, PFA, since we're still doing it at King Fahd Medical City, is really a good screening tool for primary hemostasis. It shows 90% sensitivity for von Willebrand disease and up to 100% in type 2, excluding 2N, and really good sensitivity for type 3. It shows lower sensitivity in type 1 and maybe normal when VWF is just mildly reduced. It shows limited specificity. However, a normal PFA can exclude a severe von Willebrand disease. Finally, genetic testing is not indicated in type 1 and 3 because it's a really, VWF gene is a really large one with many polymorphism noted, and is recommended for confirmation of type 2 subtype cases and the platelet type 1 Willebrand disease. With that, I conclude my talk. Thank you so much for your attention.